Yes. Okay. So a very good afternoon, everyone, and I'm Dr. Vaishali. On behalf of Center Pharma, I extend a warm welcome to our speaker, panelist, and moderator for the today's session. It brings me immense joy and honor to introduce our distinguished speakers for the today's session. We have Dr. Shishir Mirgunde, who is professor and head Government Medical College, Meerut, and he's a president of Kolhapur Academy of Pediatrics, Kolhapur. And today he'll be deliberating on the topic of neonatal and acute presentation of COVID-19 and its management. We have Dr. Sagar Lad, who has done his specialization in pediatric critical care from Australia and fellowship in neonatology from Australia. He's a senior intensivist and neonatologist at Jahangir Apollo Hospital and Sahyadri Super Speciality Hospital, Pune, and he'll be deliberating on the topic of post-COVID inflammatory syndrome. Our third speaker for today's session is Dr. Mahesh Sulakshane. He's MBBS, DCH, and MD pediatrician, a consultant pediatrician and neonatologist at Ruby Hall Clinic, Pune. And our final fourth speaker and moderator for our today's session is Dr. Sharad Ghatke. He's MBBS, MD, DCH Gold Medal from Government Medical College, Meerut. And today he will be deliberating on the topic of post-COVID syndrome overview and its clinical management. I have also privilege of introducing our panelists for the today's session. We have Dr. Swapna Shirshi, who is MBBS DCH, consultant pediatrician and neonatologist from Solapur. We have Dr. Neelam Damle, ma'am, and she's a gold medalist in DCH and consultant pediatrician from Pune. We welcome you, sir and ma'am. And I have just one request to the audience. If you have any questions, at the end of the session, we'll be taking it up and we'll be giving it to the respective speaker, and they'll be giving further information on it. So without any further delay, I'm handing it over to you, sir. And Dr. Sharad, sir, over to you.
Please.
Thank you, Vaishali. Good evening, all the delegates and speaker. Today, please off the audio. Audio बंद करो. Hello. Hello. Vaishali, hello.
You are audible, sir.
Yes, sir, you're audible.
Yeah,
You're audible.
yeah, okay.
Yes, sir.
Okay. As we all know, now we all are facing a pandemic of COVID-19. This is a virus which has made a hawk all over the world, starting from a beggar on the road up to the president of America. Everybody is affected. There is no discrimination in the age, sex, literature, or its economic status. Everybody is affected, and almost everybody is going to face the problem of this pandemic. So also, this virus is the only virus which has produced a long pandemic, because majority of the pandemics which have occurred, either they are controlled by themselves or by the human attempts. But this is the only pandemic which has lasted. I think last December we had first case, and WHO has declared this pandemic on 11th March 2020, but till today we have not developed any vaccine. We don't have a definite management. Only management is symptomatic, and this virus is very particular that it changes its nature. For example, in Kerala, there was a Kerala pattern which was developed, that using of mask, social distancing, that has definitely reduced the incidence. But now again in Kerala, there are maximum number of cases which are seen. So also there was one Sangli pattern where almost there were nil cases for many days. But now Sangli is one of the important district all over the India where mortality is highest. So all the things which are happening with these viruses are unpredictable. And because of this, even though we know that majority of the patients are adult patients. Children are also affected, and the pattern of affection is totally different and sometimes can be devastating. So today, this webinar is meant only for that purpose, that everybody, especially pediatricians, because they are more prone to develop or to undergo the disease, because we are the only doctors which directly touch the patient. Because adults, we have seen, they are not actually examining the patient by touching, but pediatricians, they are directly exposed, and a majority of the infections which are reported till now are either radiologists or pediatricians or anesthetists. So that's why this session, we thank to Centaur Pharmaceutical Company for arranging this. We have very good speakers. First is Dr. Shishir Nigunde sir. He is the person who is HOD of our medical college, and he has established almost 33 dedicated centers in Sangli and almost 100 centers of a corona care in Sangli. So over to Dr. Shishir for his talk on neonatal and acute clinical presentation and its management of COVID-19 in children.
Yes.
Over to Shishir sir.
Yes. Thank you. Thank you very much, Dr. Gadge sir, and thank you very much, Centaur, for organizing this very important webinar, because children are not small adults. They have special needs, so they should be taken care of. So you have taken initiative, and hopefully we will be doing very nice interactive session today. And though the topic of interest today's webinar is post-COVID era, this multi-system inflammatory syndrome and all these things, but we should also recapitulate the things what have happened till now. So that's why this acute presentation and neonatal presentation of children we should understand, and then we will go ahead. Let's start. Thank you. Yeah. So today we will see these issues. In neonatal issue, what are the clinical presentations? What is the management? Is vertical transmission possible? This is the topic of discussion, hot discussion today. And these pediatric issues, which children are to be tested, in which children we have to suspect, what is the typical and atypical presentation. Then their categorization. Categorization is very important for our methodical management. And management issues, what are the issues compared to adults, what are the differences, and what issues we are facing. So we will discuss in today's discussion. Current evidence suggests that SARS-CoV infection in neonates, first we will see these neonatal issues. Now initially it was thought that neonates are in neonatal infections are uncommon. If neonates do become infected, the majority have either asymptomatic infections or they have mild disease. That is, they don't require any respiratory support, what we see in adults or older children. They usually recover. Severe illness in neonates, including illness requiring mechanical ventilation, has been reported, but it appears to be very rare. Now, neonates with underlying medical conditions and preterm infants, less than 37 weeks gestation, may be at higher risk of severe illness from COVID-19. Reported signs among neonates with SARS-CoV infection include fever, lethargy, rhinorrhea, cough, tachypnea, increased work of breathing, vomiting, diarrhea, and poor feeding. Now, we see these signs and symptoms in most of the neonates suffering from other illnesses. Now, it is a clinician's challenge to suspect. So high index of suspicion to detect COVID infection in neonate has to be there. So suspect mother, positive mother presenting with these symptoms at any age, let it be first day or 28th day. So any neonate presenting with these common presentations has to be suspected with a COVID infection. Complications including respiratory distress or pneumonia. In one study, they have found in 18% of cases, and in some cases DIC-like picture in 3% of cases, or asphyxia and perinatal deaths. So these are very rare and reported from various journals. That's why I have just mentioned. Now, what happens in laboratory findings? Typical laboratory findings were minor changes in WBCs, nothing. They have just changes in lymphocyte, changes in neutrophil are very less common. In adults, we say more than 3.5 ratio neutrophil to lymphocyte is very significant and suggestive of some serious infection, but it doesn't happen in neonate. And it is there are we have to send inflammatory markers in neonate also once the test is positive. So these inflammatory markers, what we do in older children or adults, we have to send and we have to confirm. So ESR, CRP, liver enzymes, CPK and LDH and D dimers, they are mildly raised. They are not severely raised what we see in adults and older children. So lab findings are also there. And to be precise, instead of going in details, we are going to see details in pediatric management. So most of the neonates require simple symptomatic and conservative treatment. Just treatment of fever or just fluid electrolyte management and warmer care and what we take in routinely in our NICU care. So very rarely required advanced intervention. So one hot issue is vertical transmission is possible or not. Neonates have been reported to be COVID positive despite strict infection control and prevention procedures during delivery and separation of mother and neonates, meaning vertical transmission could not be excluded. What literature says, there are some cases being reported from various centers from India as well as abroad that on day one also RT-PCR comes positive. Very early the antibody IgM, IgG antibodies come positive. So it is likely that this vertical transmission is possible. We don't know in third trimester it has occurred and what would be the consequences of early infection, say first or second transmitter semester. We don't know. So the time is the answer for that. But vertical transmission is definitely possible. In our medical college also we are seeing such cases, but still we have to wait for documentation. So in short, in neonatal summary, we have to conclude that this COVID positive newborn show a good prognosis with low rate of severe complications and without deaths. I think in literature till now there is no death in neonatal age group. Treatments are prevalently symptomatic and supportive. Vertical transmission remains unproven, and horizontal transmission is the most probable source of infection for newborns as of today. So this is some neonatal issues. In short, we will go to pediatric issues now. Now, when we should suspect this child is COVID suspect. So these are the typical presentations we see day-to-day OPD pre-corona era. This fever and respiratory symptoms means influenza-like illness like cough, cold, coryza, and sore throat. There may be myalgia, malaise, headache. These we see day to day, but some new findings are there, and that time also we should suspect. Sometimes they present with the GI symptoms like abdominal pain, vomiting, diarrhea. Sometimes conjunctivitis also, poor feeding or listlessness in infant, unexplained irritability. And these specific symptoms, loss of taste or smell in older children, it is a subjective complaint by children, especially above 8 years. We can ask this history and we can confirm, because though it is rare, it is very specific to COVID. Before testing also we will come to know this is likely to come positive. So this is very specific test, and any febrile illness without localization in this era, we have to suspect COVID. And history of contact with obviously COVID positive case, and post COVID, even there may not be history of COVID positivity, but the children present with the Kawasaki like or shock like presentation. So in that case we have to suspect retrospectively COVID. And unexplained reddish and bluid discoloration of toes, though it is not seen in Indian community, we are seeing such cases in children also. This is very typical presentation in COVID. Now, clinical presentation, usually I told this is during the early stage of the outbreak, it was thought that children are very rarely affected, like neonates also. And the reasons are many. We will discuss that also. But now there are cases coming as the number of cases are increasing. And one of the studies, they say 83% of children had a positive contact history, mostly with the family members, and incubation period is 2 to 25 days with with mean of 7 days, and they could be isolated from the nasopharyngeal secretions for up to 22 days from stools and more than 30 days from respiratory secretion. So this is very significant. That's why children are more important from career point of view. They are more sources for spreading infection because they spread for 22 to 30 days compared to adults. Usually adults we say 10-14 days is okay, but children are more significant source for spreading infection. And in children, co-infections were reported in one of the studies, 79% of children, and those are mainly mycoplasma and influenza. And maybe that was the reason we use azithromycin and oseltamivir in our treatment. Up to 35% of children are seen asymptomatic in one of the studies. Now, what are the most common symptoms we see? Cough in almost 48% of children, fever in 42% of children. So without fever also we may have to suspect COVID, remember, and sore throat or pharyngitis in 30% of children. And further symptoms were nasal congestion, rhinorrhea, tachypnea, wheezing, diarrhea, as we discussed previously. So laboratory parameters, what we see usually, they are only minimally altered in children, just like neonate also. And radiological findings are just like adults only, but severity is very mild. They are very unspecific and usually include unilateral or bilateral infiltrates, and in some cases ground glass opacities or consolidation with surrounding halo sign. So these are the typical findings in COVID-19 patients, what we see in adults, but these are very mild in children. And children are rarely needed to admit in ICUs, in at least in acute phase. Later on post-COVID, now this chance is increasing. Dr. Sagar and our all team will discuss on this issue. And a small number of deaths have been reported in children globally. So this is the thing. Now, what we do in acute phase in our hospital, there is methodical treatment. Once child comes positive, we are categorizing them into 5 categories. First thing is he is RT-PCR positive, but he is asymptomatic. He was tested only because he was contact person. Somebody in the family has come positive. That's why he was tested. He came positive, but he is asymptomatic. So that category is A. Now category B, C, D, E means there are symptoms, but what are the symptoms? If they are only URTI and no comorbidities. What comorbidities we see in children, we will see in short time. Now, URTI without comorbidities, URTI with comorbidities, another category, and low respiratory tract infection without respiratory failure, and LRTI with respiratory failure. So these 5 categories we divide, and accordingly we treat. And what are the common comorbidities we see in children, in our Indian children? Severe acute malnutrition is very important. For some reason, they are immunocompromised like HIV or some long-term steroids. There can be congenital heart diseases or some hematological diseases like megaloblastic anemia, sickle cell, thalassemia, or sometimes malignancy also. We have nearby a cancer center. From there we have seen patients with a malignancy and COVID positivity. And nowadays we are seeing juvenile diabetes also. That is also comorbidity. So if these comorbidities are present, then we have to change the category and treat accordingly. Now, how will you investigate in these categories? In just mild, only positive cases without symptoms, we do just CBC. There is no much derangement, we confirm and we give the conservative treatment. In category B, category means URTI with no comorbidity, usually CBC, CRP, chest X-ray, ECG and urine is to be done. And yes, category C means URTI with some comorbidities, what we see just now. They should be thoroughly investigated in the form of CBC, CRP, LFT, RFT, ECG, BSL, X-ray, 2D echo if available, and later on CPK, MB, amylase, and everything is to be done because this child has comorbidities. We have to take special care. And other categories in which there are severe low respiratory tract symptoms and they have comorbidity, then in this case also we have to investigate thoroughly. In that case, procalcitonin, IL-6 and everything is to be done. And DCT can be done in case of anemia because there are some immunological presentations in children. That's why. No treatment. In short, this asymptomatic patients will require just supportive treatment and watch for new symptoms or signs. Or in this category B means URTI with some symptoms and no comorbidity, then we start oseltamivir, because we saw the comorbidity co-infections in children are comparatively common. That's why we cannot rule clinically this H1N1 and mycoplasma infection. That's why H1N1 test is usually sent along with our RT-PCR, and if it is negative, then we can stop oseltamivir, but initially we have to start it. And in category C, in which there are comorbidities, and this oseltamivir and hydroxychloroquine is started. Now the question is, do hydroxychloroquine work in our children, and is it recommended by ICMR? These are the questionable points, but at present we don't have anything in our hand. And before corona era, so many children and adults are on hydroxychloroquine for prolonged period. If G6PD is negative, then we can start this drug. And there are some evidences in European journals, and ICMR also advises in 15 years where this drug is advised. But to be precise, and if somebody wants a black and white answer to this, then the centers who are running drug trials over hydroxychloroquine, they can officially do this. Otherwise, this has to be used off label. And these categories D and E, they require azithromycin, oseltamivir, hydroxychloroquine, and antibiotic. Usually amoxicillin or ceftriaxone is the first choice. So this is in short the treatment. We can see in detail. Now, just a supportive treatment in the form of IV fluids. We know holiday cigar formula, every pediatrician is using that. In children with ARDS, we have to restrict the fluids to 2/3 and we have to keep watch on the kidney function. In patients with shock, aggressive fluid resuscitation, that will be discussed later on. Now, initial antibiotics which are to be preferred. In children, we prefer these antibiotics. Ceftriaxone, amikacin, this can be chosen. And the second line drugs are piperacillin, tazobactam, and vancomycin, depending upon the situation. But before starting the antibiotics, one must keep in mind we should send blood culture before giving first dose. Okay. Now, steroids. What is the role of steroids in pediatric COVID management? We do not routinely give systemic steroid for the treatment of viral pneumonia or ARDS unless they are indicated for another reason. IV hydrocortisone or dexamethasone 30 minutes single dose before extubation is acceptable. In adults, there is evidence for use of low dose of steroids in cytokine storm. However, pediatric data is insufficient to recommend use. So steroids are sparingly used in pediatric management, especially acute management. We will see post-COVID management. Now, just to summarize, just to revision for treating pediatricians, in what doses these drugs are given. Azithromycin 10 mg per kg is recommended, not 20 mg, what we advise in some other diseases. It is to be given for just 5 days. Oseltamivir dose, just for revision, less than 12 in infants less than 3 months, 12 mg twice daily. 3 to 5 months, 20 mg twice daily. 5 to 11 months, 25 mg twice daily. And above 1 year, less, depending upon the weight criteria, this is 30 mg twice, 45 mg twice, and 60 mg twice, depending upon the weight. And in adults or more larger children, it can be 75 mg BID. And hydroxychloroquine, what is the dose? It is to be given 5 days and 6.5 mg per kg per dose. The BID on day 1, followed by 3.25 mg BID for 5 days. Neonates dosing is not established, and its use is also there is no very less literature to recommend that use. Now, doxycycline is being used by many pediatricians in other states. Task force also advise this ivermectin and doxycycline. Dose per kg in children is 2.2 mg per kg twice daily for 5 days, and ivermectin is 100 microgram per kg per dose twice daily for 3 days. And lopinavir and ritonavir was previously used when remdesivir was not available, because this is a available drug in most of the medical colleges for retroviral treatment. and this dose was calculated by lopinavir, 16 mg per kg dose twice daily, and later on this depending upon the weight this drug was used. But nowadays this is not recommended. Remdesivir was preferred, but still remdesivir or any other antiviral, let it be favipiravir, its dose is there is no adequate recommendation for its use in pediatrics. And these are just theoretical, very rare situations where we may come across the use of tocilizumab or enoxaparin. Now, if the inflammatory markers are very high, and in that case, we may have to start enoxaparin. And very, very rarely, I don't think anybody has used tocilizumab even acute phase or even post-COVID multisystem inflammatory syndrome. So just to know, its dose is 4 to 8 milligram per kg. Its pediatric preparation is available, though it is not used. 80 mg and 200 mg vials are available along with adult vial of 400 mg. So it is available in children, but its use is not at all commonly seen in any of the institutes. And enoxaparin, depending upon the situation, we may have to use. It is 0.5 milligram per kg dose twice daily subcutaneously. So it is under expert guidance only we have to use. Now, just to summarize, this is a initial ventilatory settings in case of rare event of respiratory failure category E patients, where we may have to use. So rate depending upon the age, we may have to start infants 30, 40, 2 years, 30 per minute, and older children lesser. So PIP is 20 to 20, 12 to 20 centimeter or whatever. PEP is 6 to 15. And in case of ARDS, we may have to give more depending upon the lung compliance. And tidal volume, it is 5 to 8 ml per kg, FiO to 100% initially, and titrate as per the FPO to SPO2 ratio, and depending upon the situation. Patient's position usually 30-degree head elevation and prone position if severe ARDS. And early proning is beneficial in severe diseases. This proning, as is experienced in adults, it is also useful in pediatric patients. And this ABG and PaCO2 is permissive hypercapnia if pH is less than 7.2. Neuromuscular blockade is used if there are sedation is not working. Sedation is usually preferred in children, and suction as required. Usually it is the inline or closed suction is preferred, because we want to prevent aerosol generation and protect our healthcare workers. Infection control, we have to prevent ventilator associated pneumonia and this CLS, CLAPSI and everything. And nutrition we have to maintain, and mobilization to prevent the bed sores in case rare event of prolonged treatment in children. So this is the in short management of neonates and acute presentations of children in today's era. Thank you very much.
Thank you, Shishir sir.
Thank you.
Yeah,
It was an excellent presentation. Most of our doubts have been really clear.
Yeah.
We just have one question that nowadays the mothers who are COVID positive ask whether they should be breastfeeding their babies or not. So what would be your recommendation?
Yes, absolutely. This is a question for every positive mother in today's situation, and there should be a clear message from WHO or all authorities that COVID positive mothers should breastfeed to their babies, provided they take all necessary care for horizontal transmission of its infection. That means they should wash their hands before feeding, every feeding. Then they should use mask, and then the respiratory etiquette should be maintained. So with these precautions, they should breastfeed the babies. There is clear message from myself as well as from all authorities. Every mother should breastfeed her baby, even if she is positive or symptomatic.
Okay, thank you, sir, for clearing the doubts. One more question is regarding the immunization. The parents prefer to postpone the immunization. So what would be your take?
Yeah. This is a very good question and very practical question. And this is from epidemiological point, it is very important, because it is seen from statistics as well as practically nowadays, because of COVID fear and because of lockdown period, the parents didn't turn up to immunization either to government institute as well as to private practitioner, private pediatrician. So this immunization coverage has drastically decreased from 80-90% to 50-60%. So there is serious fear that is any one more non-corona epidemic is waiting for us, because these triple Hib and pneumococcal and rotavirus and all infections may come up because of this reduced coverage of vaccination. So every parent must be aware of this, and they should try to go to pediatrician or government institute, and they should cover their routine immunization to their children.
Okay, thank you, sir. It was really a nice session.
Thank you.
Over to Dr. Vaishali.
Thank you.
Thank you. Thank you, Mrigunde sir. It is definitely a nice presentation. You are a professor of pediatrics. all of your students are definitely happy. Most of the doubts about the pediatric and neonatal COVID is definitely cleared. Sir, thank you very much. Now we'll switch over to another topic. Dr. Sagar Lad. Dr. Sagar Lad, he has joined. Yes, he is pediatric intensivist, highly learned from Australia. Now working in the Jahangir Hospital and in the Sahyadri Hospital, Pune. He has a tremendous experience as far as the COVID infection is concerned. He has many cases which he is going to present to us. He will be talking on post-COVID inflammatory syndrome. Thank you, sir. You start your speech.
Thank you, sir, for the introduction. Sir, are you able to hear me?
Yes, sir. Yes, sir.
So, what I'm going to discuss, good afternoon, everyone. And I first like to thank the Center of Pharma for giving me the opportunity to speak on this topic on this platform. And what I'm going to discuss about the variable representation of a pediatric inflammatory multisystem syndrome, or MISC, that is multisystem inflammatory syndrome of the childhood. Now, I'm going to discuss in brief about some virus structure, case discussion, the definition, management, neurological manifestation, the Kawasaki disease, toxic shock syndrome, their management, and immunomodulation. So we all, since last 3 months, we are learning about this virus. We on the structure of this virus. Just I want to mention about here is about the ACE receptor. Very important. This is called as a spike protein, and this spike protein is important to join with the ACE receptor, and we are interested on this ACE receptor. Now, this virus also has got a M protein and also has got a membrane protein. And this membrane protein is important to keep the intactness of the virus. And when we do a hand washing and disinfectant use, that membrane protein breaks down. Now, why the children are not suffering from the severe disease? There are lots of hypothetical information that we give the vaccine to the child and their immune system is intact when we are vaccinating the child. They are active immune response. Secondly, there is early isolation and movement restriction because of closing down the school. And very important is the ACE receptor. Now, this ACE receptor is less expressed in the respiratory tract in the children. That's why they are less affected in the respiratory virus. And a third thing is that there is no absence of any high-risk factor like aging, comorbidities, and the diabetes like nature, or a less degree of obesity and the smoking. But there are a high-risk group like in the children less than 1 year of age, or a children with a pre-existing disease like neurological disease, chronic lung disease, asthma, and uncorrected heart disease. Now, what is mean by the PIMS and what is mean by the MISC? Now, case definition of a PIMS. Now, the first case of a PIMS, that is called as a pediatric inflammatory multisystem syndrome temporally associated with the SARS-CoV-2. The first case was reported in April 2020. Similar case definition has come up by the CDC and WHO, and they called it as a multisystem inflammatory syndrome in the childhood. So these both are synonymous to each other. UK called it as a PIMS and US called it as a MISC. Approximately so far 275 cases has been reported in the worldwide. Now, if you compare this disease with the adult, now if you see this graph, it shows that this stage phase is called as a hyperinflammation phase. Now, this hyperinflammation phase is seen in the children, seen in the adult as a stage 3. Now, they went in early infection, pulmonary phase, and later on it came as a cytokine storm syndrome. Now, this cytokine storm syndrome is equal to our PIMS-TS presentation. Presentation-wise, it is the same, but there is no such initial presentation like stage 1 and the stage 2. Now, what is the spectrum of PIMS-TS? PIMS-TS has got a 3 spectrum. First spectrum, they are associated with a febrile inflammatory state, which is called as a FIS. Now, in the FIS or febrile inflammatory state, the child has got a persistent fever with a mild symptom like headache and fatigue, but inflammatory markers show only high ferritin, but rest of the inflammatory markers are normal. So these children doesn't need aggressive treatment. Second category is a Kawasaki disease, which present as incomplete or complete Kawasaki disease, need aggressive treatment. And third category is a toxic shock syndrome, which present with a severe form of a marked inflammatory cytokine storm with multi-system involvement. Now, there is no strict watertight compartment like this is a KD and this is a TSS. It may be the overlap of these two the child can present. Now, we'll start with the first case. Now, I'm going to discuss about the 5 cases, and these are the scenario that really faced real cases. Now, this is a 6-year-old child who presented, I think, in the first week of May with history of a fever since 3 days, cough, cold. Fever was very high grade, very classical of PIMS-TS. You get very high grade fever, and this high grade fever doesn't settle with your antibiotic agent. It's persisting high like 102, 103, 104, which is not settling to paracetamol and not touching the baseline. Mother is a lab technician. Father was a COVID positive 1 month back. The child was tested at that time, was a negative. When the child presented to the emergency, he was a febrile, chest was clear, BP was maintained, but he had of edema of a hand and a feet. He started as usual with the ceftriaxone, AZ, anti-flu, and the antibiotic agent, and routine blood test was done, doing like a CBC, CRP, blood culture, dengue, malaria, and rapid malaria was sent. Now, 6 hours after admission, the child started deteriorating. His fever continued. He started getting a low blood pressure. Capillary refill started becoming more than 3 seconds. Hemodynamic stability started. So the inotropic support was started, and he has got a low GCS. So the child was intubated, and the central line was inserted, and the child was shifted to the pediatric intensive care unit. Now, if you see this lab, now this lab has seen on admission, the child has got a fairly good hemoglobin, but subsequently later on, the hemoglobin started dropping down. His count was initially okay, but later on he started getting a low platelet count. His CRP started climbing up. His ferritin started going up. His D-dimer was almost 10,356, which is very sky high. Interleukin 6 was 23 and LDH was 462. So this was the initial lab parameter, and so there was a diagnostic dilemma. Now, this case, which was come in the first week of May, first or second week of May, and at that time we say, what is this child is having? Initially, the impression was the child has got a septic shock, RT-PCR was negative, and it was a very much diagnostic dilemma. Considering the pandemic, we have done the SARS-CoV-2 antibody, and this antibody was positive. So it was a 7.17. So it was a confirmed case of the pediatric inflammatory multisystem syndrome, as this antibody was positive. Echo was done, which shows a left ventricular dysfunction with a normal coronary. So the diagnosis was established as a PIMS with a toxic shock syndrome was confirmed. But he hasn't got any coronary involvement, so it was not a Kawasaki-like picture. This child was treated with methylprednisone in a dose of 10 mg per kg, intravenous immunoglobulin of 2 gram per kg, and subsequently child settled down, been down to ventilation, and child stable and sent home. He received a low molecular weight heparin as his D-dimer was very high. I will come with the standard guideline what we practices. Now, a second case is a 2-year-old child who presented with a high-grade fever on and off with excessive sleepiness, with a maculopapular rash over abdomen, edema of a hand and feet. On examination, the child was okay, hemodynamic stable, but has got a tachycardia, maintaining BP. The pupil was reacting. GCS was 9 to 10. The parent is IT, and they are saying we are at home since last 3 months. Clinically, it looked like query dengue, query rickettsia, query sepsis. This was the initial X-ray, which was not little bit infiltrate on the right side, and there was little bit of a cardiomegaly. Now, as routine things, we started this child on the ceftriaxone, azifluvir, and vancomycin. Initially started on oxygen, but then shifted to the HFNC as the oxygen requirement has started climbing up. BP was low, so inotropic support was started. He has got excessive sleepiness. That was the important presenting feature. So considering his hyponatremia and excessive sleepiness, we started an anti-edema measure like 3% sodium chloride in a dose of 0.4 ml per kg per hour. Hypokalemia was corrected, but again, it was a diagnostic dilemma, whether the child has got a viral exanthem, whether he has developing myocarditis, or whether it is the form of encephalitis. So again, the inflammatory parameter and the lab parameter was done. We show a normal platelet count. We show initially the sodium was low, but sodium subsequently went down up to the 128. CRP from beginning was very high. D-dimer was very high. Ferritin was very high. Very important, I want to stress over here is a pro-BNP. Now, pro-BNP is a very important cardiac marker. Now, usually it is done in adult quite frequently, but whenever you get a COVID-related or a post-COVID inflammation of the heart involvement, pro-BNP is very sensitive marker, and the normal level is up to the 125 to 150, but his level was up to the 6,475. SARS-CoV antigen RT-PCR was negative. Because of excessive sleepiness, the CSF was done, which was normal, and his MRI was done, which was normal, but there was a changes of a splenium of a corpus callosum changes. Again, I will come to this information later on. So the echocardiography was done because again, we suspected it is of the COVID. We have done the antibody test, which was positive, and echo shows a dilated coronary of left main coronary was 3.55 with a Z-score of 2.7. LAD left anterior descending, the Z-score was 5.15, and there was a left ventricular dysfunction and dilated IVC, and very importantly, a mild pericardial effusion. So when you say about a coronary, always ask for the Z-score because it is specific to their age and their weight and the height of the child. And Z-score more than 2.5 is classically confirmed the dilatation of the coronary. Diagnosis was viral myocarditis or Kawasaki, but again the SARS-CoV antibody was positive, so confirmed to be PIMS, and this child was treated again with a methylprednisolone with a 10 mg per kg intravenous immunoglobulin. On a day 5, the child started bettering, weaning the oxygen, nasal prong, and she was shifted to the ward and again discharged on the day 9 on the aspirin and the zinc. Now, when to give a high dose of the methylprednisolone and when to give low dose of a methylprednisolone. See, again, we stated in this child at 10 mg per kg, and it can go up to 30 mg per kg. There are no as such guideline, but the severity of a disease is high. You can give up to 30 mg per kg. If the child is in a shock, you give a pulse dose. If the child is not in a shock, then you can give 2 mg per kg of a methylprednisolone. Now, in this child, the third child is the same like a Kawasaki disease, and what we also found that these children are get a conduction abnormalities. Now, this is because of this virus also involved your myocardium and the SA node, like what we see in the dengue. Like dengue get a bradycardic, and also the heart rate can come to the 40 and 30, and sometimes the child need a isoprenaline infusion or atropine also. Now, what we have observed in these children is that because of their involvement in the conduction system, they has got a heart rate. Now, if you see this child got a heart rate about a 70 to 80, but it was in the sinus rhythm. There was no acidosis, maintaining the BP, conscious. So this bradycardia was not treated, and subsequently, as the child improved, the heart rate came back to the normal. Similar conduction abnormal. This is again a child with the Kawasaki disease. We noted that this child has got low heart rate, and this was again the sinus bradycardia. Some atrial ectopic were there initially, but subsequently they settled down, not required in the antiarrhythmic agents. Now the fifth case is the 9-year-old child who presented with a history of a very high grade fever of 104 with 4 days history, with severe abdominal pain since 2 days, loose motion, facial edema, edema of a hand and a feet, and mild conjunctival redness. On admission, the child was febrile, tachypneic, but there was no guarding, vague abdominal pain, and BP was maintained. Blood evaluation shows a high WBC count, but there were high inflammatory marker like a CRP was a 22. So what was this? Now, initially it was thought that this child has got the acute abdomen, whether it is like acute appendicitis or whether it is perforated appendix. So the ultrasound was done, and the surgeon was involved, and the conclusion was it was like appendicitis. CT was done, which was shown there is a thickening of ileum, free fluid abdomen, But surprisingly, the spleen, there was suggesting of some hypodensity in the mild and the mid and the lower pole, suggestive of the splenic infarct. So the ferritin, D-dimer and LDH were done, which were highly positive. RT-PCR was negative, COVID antibody was positive, and it was the same PIMS-TS. So what we learn from this case is that the children start presenting as an acute abdomen. And when you get acute abdomen with high-grade fever, if a surgical call is ruled out, always think of the pediatric inflammatory multisystem syndrome. All his cardiac marker were done, which were positive. Echo was done, which show coronary dilatation. Again, the children was treated with methylprednisolone, IVIG, Clexane, aspirin, and he was discharged on day 10. So it is again unusual presentation with acute abdomen, which mimicking appendicitis with persistent inflammatory marker. Now, similar cases has been reported in Journal of Pediatric Critical Care from Dr. Vinayak Patki and the team and Dr. Bal Mukund. And they have reported a 4 cases series which presented with cardiogenic shock and the Kawasaki disease. And so far now, slowly the cases have started coming up with this syndrome. Now, what is the proposed mechanism of this disorder? Now, the proposed mechanism is called as an antibody-dependent enhancement. Like this is the antibody. Now, this antibody get attached to this virus. Now, this IgG level are usually of a low titer. So that low titer IgG does not provide you the protection. But this level is higher enough to enable the virus to spread the infection. So this is the antibody that virus get attached to the antibody, and this get attached to the cells. Now these cells usually antibody that enter into the cell, and subsequently the virus and this Fc receptor of the antibody, they are produced enter into the cell, and this produces infection and the non-infectious virion. So this is called as antibody-dependent enhancement, and these are demonstrated antibodies to the, especially these antibody are to the spike protein of this virus. Second mechanism is called as a super antigen disease. Now, super antigen disease, what we see in the children with the with Staphylococcus dead skin syndrome, like that they have got a similarity. Now, this spike protein has got a similarity to the bacterial super antigen, and this directly bind to the T cell. So if you see this T cell, this super antigen, this antigen, conventional antigen to the bind to the T cell, and it will produce this T cell get activated. But if there are too much antigen, now this super antigen attached to this T cell, and there is T cell releases cytokine storm. So such information has been contemplated that the super antigen disease can cause this PIMS-TS. Now, the PIMS-TS, there is a notable absence of a pulmonary and a renal symptom. Generally, there is not much of a renal and the lung involvement, but these children has got the association between the COVID, because 2 to 4 weeks down the track, the development of the COVID antibodies. Now, in comparison to the D-dimer, now initially we never tested this D-dimer, and because of this COVID era, we started testing this D-dimer, and we also noticed that these children usually has got a normal coagulation test. PT-PTTK is normal, but coagulopathy is usually seen in an adult, but not in the children. Now, what is the spectrum of this PIMS-TS? Now, this PIMS-TS can present as a hemodynamic manifestation, like the child can present as a shock or may present as a vasculitis of a heart vessel or a brain vessel. So, or maybe a child may produce a major inflammatory response. The child may become normal or may develop a coronary involvement or the heart involvement. Now, this PIMS-TS has been described by the WHO as the children between 0 to 19 years with the fever more than 3 days. So, any child, if you are in the OPD and getting a fever more than 3 days, which is a very high grade, not touching the baseline, you need to think of this disease. Now, he may develop like conjunctivitis, may develop like a hypotension shock, may develop cardiac involvement, may evidence of coagulopathy. Very important is the gastrointestinal symptom. We have seen the children who are presented with a persistent diarrhea, vomiting, acute abdominal pain can be a manifestations of the PIMS-TS. Obviously, you need to rule out there is no other infection in the body, increase the level of inflammatory marker. RT-PCR may come positive in 10% of cases and 90% are antibody positive. Similar definition has been given by the CDC, but CDC says that fever is more than 24 hours. Now, CDC also said if the child has got a fever more than 24 hours and persistent, not settling down, you need to find out the cause. And all the markers are elevated. There is involvement of majority of system like cardiac involvement, renal involvement, neurological involvement, hematological involvement, gastrointestinal involvement. So these are the information given by the CDC. So any child who has got a fever, which is a very high grade, he has got a rash, conjunctivitis, abdominal pain, diarrhea, vomiting. So GI manifestation, headache, you need to consider this as a differential diagnosis. He may develop a shock, myocardial dysfunction, ECG abnormality, coronary dilatation later on. If you see a blood parameter, you get a low lymphocyte count, high neutrophil count, very high CRP. It may be in the 3-digit, 100, 200, 300. No obvious focus of infection. Very important, low albumin level, very high level of ferritin, very high level of fibrinogen, very high level of a D-dimer, and troponin T, and very important is a pro-BNP. So you should do, if you suspect it, always do a pro-BNP. So these are the markers that are usually positive. So how early you can get the development of antibody positive? Now this is a graph which is showing when a child get infected, you see this is the SARS-CoV RT-PCR. Now this RT-PCR start dropping down from day 10 to day 12, but after as early as a 1 week of the time, this IgG antibody start increasing. So as early as a 2 week, but they say up to 2 to 3 weeks also, the can get a high level of IgG. Now, some few information of Kawasaki that we all know about the Kawasaki disease, that is autoimmune disease, and which is presented secondary to the various bacteria and viruses and fungi also, and adenovirus, human metapneumovirus, coronavirus, parainfluenza, Epstein-Barr virus. And this is seen in the children only because of the underlying architectural defect and hypothesis because of a disorder of the T and the B cell. Now, what is a typical and atypical Kawasaki that we all know as a pediatrician? Complete Kawasaki, fever more than 5 days with cracking of lips, then erythema of bilateral bulbal, non-purulent bulbar conjunctivitis, rash, edema of the hand and feet, cervical lymphadenopathy. Incomplete Kawasaki is a fever with less than 4 clinical picture like high CRP, high ESR, echocardiogram. I already told you the echocardiogram finding, very important. You need to find out the Z score. If a Z score is between 2 to 2.5, it is a doubtful and the child may landing up into the dilated coronaries. Very important, majority of the children, what we found out that they have getting a development of a pericardial effusion. And similarly, you get a high platelet count, anemia, hypoalbuminemia. So this is an incomplete Kawasaki. Now, what is the difference between the classical pre-pandemic Kawasaki disease and PIMS-induced Kawasaki disease? The age of onset in the PIMS is usually later on, 7 to 9 years, as compared to the normal is less than 5 years. And all the markers are like gastrointestinal symptom we are seen more in the PIMS, cardiac involvement, coagulopathy, shock, very marked elevated CRP, very marked elevated pro-BNP, and thrombocytopenia. Normal, what is a traditional teaching, Kawasaki usually has got after 1 week a development of thrombocytosis, but these children usually presented with a thrombocytopenia and a coronary abnormalities. This is again given by the Canadian Society of the in May 2020. Now, this is a child who presented to me from the Ahmednagar with a history of a fever with a very high inflammatory marker, and classically you can see a non-purulent bulbar conjunctivitis with lymph nodes bearing. Sometimes you get subconjunctival hemorrhage and erythematous rash, maculopapular rash. Again, coronary was checked, and she has got a dilated coronary with Z score about a 4.17. So it was a confirmed Kawasaki, and she was treated with methylprednisolone and IVIG and subsequently settled. Similar, this is a child who is presented in the adult. It is almost a 16-year-old child who presented initially in the corona ward with a fever, and but subsequently found to be landing up into the PIMS. And you see here is a bilateral conjunctivitis and strawberry tongue. Now, this child again was very bad. We initially thought that like adult oriented, you treat with methylprednisolone, but we treated him in the IVIG. His initial interleukin 6 was almost 256, and the plan was to give him tocilizumab. We treated him a complete course of a 2 gram per kg of IVIG, a 30 milligram per kg of methylprednisolone. And subsequently, after 48 to 72 hours, his inflammatory markers started coming down and child improved. His again his T-dimer was very high, and we treated with low molecular weight heparin. Now, this same what I mentioned now about this management of the child with KD, IVIG. Now, aspirin. Now, when to give a corticosteroid? I told you methylprednisolone either 10 to 30 milligram per kg. Usually, it is given for 3 to 5 days, and subsequently you shift it to the 2 milligram per kg of the maintenance dose. For how long you need to give the prednisone? Now, current guidelines say if the child is very sick, you can give a 3 to 4 week. If the child is not too bad, you can give a 2 to 3 week. But this child needs to be on steroid supplementation. Now, about the dose of aspirin. Now, aspirin was given an antiplatelet dose of a 3 to 5 milligram per kg per day, and it has to be continued for 6 weeks to the 8 week up to the 3 month also. Now, shock-like state, some children are presented like a toxic shock syndrome and shock-like presentation. Now, when you get a child with a shock-like presentation, always check his heart, check his inflammatory marker, echo, and do a pro-BNP and the TROP-T also. Because this toxic shock syndrome children may need aggressive treatment with inotrope, fluid resuscitation, ventilation, and antibiotic also. Now, this is again a toxic shock syndrome picture with a hypotension with more than 2 laboratory finding of a fever, rash, renal impairment, coagulopathy, and abnormality in the liver enzyme. Now, what we recently found that some children are presented with neurological manifestations of COVID-19. Now, this neurological manifestation in the PIMS are seen as encephalopathy, convulsion, headache, dysarthria, dysphagia, meningism, and cerebellar signs. Now, what is the mechanism? That ACE receptor are expressed in the neuroglial cell, and attachment neuron and the glial cell, and attachment of this virus to this receptor leading to the central nervous system involvement. Secondly, because of cytokine storm, it is immune-mediated damage. And secondary, because of the immune-mediated new CNS antigen get exposed to this cytokine storm, it causes damage to the blood-brain barrier. And this virus directly enter into your blood vessel, causing the endotheliopathy. And it is because of an immune-mediated attack on the central nervous system. Very importantly, what we found is that majority of the children get a development of involvement of a splenium of a corpus callosum. Now, this splenium of a corpus callosum has specifically found, this is again a journal in the JAMA, and this JAMA journal has reported that in their case series, about 10 patients, almost 60 to 70% children has got a splenium of a corpus callosum involvement, and this represent the focal intramyelin cytotoxic edema secondary to the inflammation. On similar line, we have submitted the case scientific letter to the IJP, and this will be available online next week. And what we wrote that, what we found that there are neurological manifestation in the PIMS, and we also found on the similar line. This is again with Dr. Pradeep Suryavanshi and myself, and we published in the IJP. IJP has accepted it, and we also found that about in our 7 children, almost 3 children had development of this splenium of a corpus callosum involvement. Now, I will just go a few words of tocilizumab. Sir already has discussed about it. Tocilizumab, I so far not has used in India. I think only one person from the Chennai, Dr. Bala Ramakrishnan, has used it. But the indication of a tocilizumab is only in the MISC is first you give steroid, you give IVIG, no response, you give a tocilizumab. Now, the contraindication is a life-threatening infection, hepatitis, and the bone marrow suppression. About a few words of anticoagulation. Now, anticoagulation is usually not required in the children because not they are as thrombotic like is in the adult, but the children with a high level of a D-dimer, almost 4 to 5 times of the normal, if they have got the Z-score of coronary more than 3 to 3.5 or more than 10, definitely, and LV dysfunction, LV contractibility is poor, definitely the children needs the low molecular weight heparin 0.5 to 1 milligram per kg. How long we give it? Usually for 1 week. While going at home, if the marker are coming down, you can stop it. I told you about the aspirin, how long you need to give it. This is in nutshell just information. Now, if the child has got a COVID-19, it is just acute infection, what sir has already discussed. Multisystem inflammatory syndrome has got a 3 component. One is like Kawasaki-like disease. If there is a no shock, no coronary dilatation, you need to give aspirin, IVIG, methylprednisolone. If there is a shock, definitely, and sometimes we need the tocilizumab also. Second category is a called FIS, that is a febrile inflammatory state. This may present with a high ferritin level, but doesn't need any treatment. The child settle down, but you need to monitor the child. And third stage is a toxic shock syndrome. Obviously, this toxic shock syndrome needs inotrope, vasopressors. Now, our opinion of experience is that if you use a steroid in a high dose, automatically IVIG requirement may come down or may not need. But generally, because IVIG is costly, not all patients will get the IVIG. But you start with a high dose of pulse dose of a steroid, and automatically the child will start responding. Obviously, if there is LV dysfunction, you need to cardiac support the child may need. Now, just last 2 slides. Now, this is a current guideline which has published in the Lancet just 2 weeks back. The clinical management and guideline in PFs, they have also mentioned that the first line is the IVIG. If there is no response to IVIG, you can use the second dose of IVIG. Also, high-risk children are usually less than 1 year of the child. Second line of a treatment you can use is the methylprednisone, and if there is no response, you can use the infliximab. And similar management with a toxic shock syndrome, you give first IVIG, methylprednisone as the second line of a treatment. Antiviral, only time tested is the remdesivir, is only choice, but it is in the acute infection, not in the pills. An antiplatelet agent, you should continue it for the 6 weeks. So in summary, even if you get a child with a suspected PIMS or MIS, if presented with acute febrile illness, but any child with a fever, if presented a feature of a Kawasaki myocarditis shock-like picture, vomiting, diarrhea, abdominal pain, or appendicitis-like presentation, altered level of consciousness, meningoencephalitis, myelitis, initial show inflammatory marker with high neutrophilia, lymphopenia, thrombocytopenia, high level of a D-dimer, always think of the PIMS or the MIS, and associated with COVID antibody positive. However, certain principles should be kept in mind when you treat a suspect of PIMS. This PIMS is not so common. Like all children is going to get a PIMS? No, it is rare. The children with this syndrome can deteriorate very rapidly and quickly if it is properly managed appropriately and as early as possible. And there should be a high degree of a suspicion of this disease. And it is believed that if you treat it early, the response is usually good. That's all, sir. Thank you.
Thank you, sir, for the elaborate description. It was really a nice journey. We went through all the PIMS, TSS, and this. I wanted to ask the same question, ki how can you know which child can land up in the PIMS or TSS? Like can we at our level catch the child earlier? Can you guide us on that?
Yeah, that is the thing, ma'am. That not like that ki all child with COVID antibody positive is going to land up in the PIMS. It is only because your immune system, dysregulation of immune system of a T and a B lymphocyte is going to land up into the PIMS TS. But there should be a high degree of suspicion and a high time because everywhere the cases have started coming up. So if you get a child with a very high grade fever, there is no obvious focus of infection. The child is deteriorating. The fever is not settling down. With systemic inflammation, like the child has got a rash, child has got a joint swelling, even acute abdomen, even there is a decreased level of consciousness, you should think of it. It should be in the back of a mind. Whether it is, we know it may be brain meningitis, it may be encephalitis. We are on the right track. But try to, like I will tell you, like when you are doing the inflammatory panel, add a COVID antibody as a test. It costs about 600, 700, but that will give a lot of information because majority of study has shown are antibody positive, but antigen may be the negative also.
Yes, thank you, sir. Thank you, sir, for clearing that out. Another question is, what is the mortality rate among the children landing up in these complications?
Yeah, so if you treat early, the mortality is less. Now, right now, we don't know how this Kawasaki children is going to progress. But we try to treat them early. There is a less chance of getting them the dilatation and the aneurysm. But if the child presented with a toxic shock syndrome, the mortality is definitely high. Now, so far we have managed almost 25 cases. Almost 2 children they was not able to survive because they present in a shock-like state. So before they land up into the shock-like state, if they treated, then outcome is almost good.
Yes, thank you, sir. You have really cleared our doubts. It was an elaborate description and all our doubts are being cleared. Thank you so much.
Thank you.
Over to Ghatge, sir.
Thank you, madam. With the period of lockdown and with this all pandemic area, we are definitely having some psychological problems as far as the doctors are concerned, as far as the parents are concerned. Still, we have problems which are exaggerated in the children because there is no school. Whatever you want to learn is with the mobile. Previously, when child used to take the mobile, mother used to say, leave that mobile. Now, why you don't take up the mobile is the scenario. All these things, the things which were asked to do, now they are asked not to do. And the things which were asked not to do, now they are going to do it. So all the babies of the patients, all the relatives, especially children, they are more prone for some psychiatric illness. I request Mahesh Sulakshmi sir to start his lecture on the psychological effects of COVID-19.
Thank you, Dr. Ghadge. Thank you. First of all, let me congratulate Dr. Sagar Lad and Dr. Shishir Murgunde for an excellent presentation. We have got a clear picture about the COVID scenario, COVID in children. So what is most neglected part currently is the psychological effect of this COVID-19. Though I'll be focusing on the psychological aspect of the COVID-19 in children, I'll also be talking about in general psychosocial aspects of COVID-19. First of all, let me introduce. My name is Dr. Mahesh Sulakshmi. I am a consultant pediatrician and neonatologist working in Ruby Hall Clinic, Pune, as well as Jupiter Hospital in Pune. As all of us know that Dr. Ghadge has just mentioned that there's definitely a huge impact on the screen times and the usage of mobile in children. But more important, what has happened, the disease, more than the disease, the fear of the disease has increased so much that everybody is in a corona phobia. So typically corona phobia is nothing but the fear of corona. All of us, almost every single person on the earth is going through this. Why this corona phobia is basically because of the high infectivity rate and the moderate fatality rate. The infection is spreading so high and there's so much of buzz about the corona that everybody is fearing that we might get the disease, and that's why the corona phobia is coming up. So it has caused a universal psychosocial impact. There is a mass hysteria. People are talking only about corona and nothing but corona. And this has definitely impacted the usual life which is going on. There's a huge economic burden, as you see, with the lockdown and the national lockdown and a complete standstill. There's a lot of economic burden in all the strata of the society, whether it's a poor or whether it's a financially strong person. There's definitely some amount of economic burden is always there. There's a lot of social, financial losses also, which we have encountered. This is mainly because of the forced quarantine. The government is told to be inside home. If you have a disease, if you don't have disease, the national lockdown has caused these financial losses. And this has created an acute panic in the public. Everybody is in a state of anxiety. There's a lot of obsessive behaviors which is going on because of this corona. There's a lot of hoarding of groceries and toiletries. We have seen in the news that people are stacking up the groceries and keeping things in their house, and this has caused an acute shortage of the groceries and has caused a lot of demand-supply mismatch. There's a lot of paranoia associated with the disease. There's a lot of depression, and some are suffering with a long-term post-traumatic stress disorder as well. So infodemic. So just like a corona pandemic, we have an information pandemic, also known as infodemic, through the social media spreading. So social media, WhatsApp, Facebook is spreading the news of corona so much so there's a lot of racism which is happening. People are trying to sort of label this disease to certain races and trying to separate them. There's a lot of stigmatization which is associated with this disease. We have seen some communities are being targeted that you are spreading the disease and this disease is because of you. There's a lot of stigmatization because of disease. There's a xenophobia. Xenophobia is nothing but hatred towards foreign people or hatred to a foreign person. So this is seen in mostly the Western countries as well as some part in India also. We have seen that xenophobia is spreading. We have a lot of fake information spread through the WhatsApp and Facebook. All of us have experienced firsthand. There's so much of wrong information or inadequate information which is being spread through the social media. this has caused a lot of panic and confusion in everybody's mind. Forget about the common public. The doctors themselves have gone through this confusing statements from different doctors, different opinion leaders, the political figures. They are giving different numbers, different strategies to fight this disease. The different world leaders also using different strategies to this disease. So this has created a confusion, total confusion, and ultimately land up with the delusional symptoms. All of us have feared that we might have had an episode of in corona, or every evening we think that, okay, I have a sore throat and I have a little bit of fear and probably I have a corona now. So these are the typical delusional symptoms which all of us have gone through. And this is mainly caused because of the information which is spreading in the social media. This also has caused uncaring attitude towards the food ingestion. So some people are labeling with the non-veg food causing corona and the Chinese food causing corona. So this has caused a tremendous uncaring attitude towards this food ingestion. This has also caused an uncaring attitude towards political figures. You have seen the US president fighting, the Chinese president fighting over this issue, and there's a lot of economic disturbances which are happening, and everybody is trying to relate this corona to the economic setback which the world is going through. It may be partially true, but probably we are attaching it to the corona way too much than it may be needed. It has led to the violation of basic pandemic rule. We should understand that what is pandemic all about, how to deal with this pandemic. So we are our focus on the mitigation of the virus or reducing the viral load. We are focusing on these issues, and probably we are violating the pandemic rules. We are ignoring the solemnity of pandemic. It's very important. We have to actually accept that there is a pandemic and you have to follow certain rules. Don't get diverted because of all these issues which may not be relevant to the pandemic. So this has caused a lot of oppositional activities. Some people are pro for using masks. Some people are not using mask just because there's some information which probably gives less oxygen. You might land up with some hypoxic events because of usage of the using of mask. So this has caused a lot of oppositional activities, and there's a lot of social disobedience. People are like gathering on the road just to sort of show that they are against what is corona phobia. So they are doing what they want to. This has caused a lot of therapeutic misadventures influenced by social media. So social media has come up with different ideas to fight with corona. They've told you to take steam, they've told you to take gargles, and some homeopathic medicine, some Ayurvedic kadhas, and even allopathic medicine also to be blamed. People are taking 1 kg of medicine every month, which is absolutely wrong, and this has to stop somewhere. This therapeutic misadventure we have seen causing grave problem in children as well as in adults. So you have to understand there is some limit for usage of this medicine. Only in a needed public you may need some kind of medicine which are clinically proven, but again the rest of the medicine should be avoided. There's a lot of anti-Chinese sentiments which have come up with the kind of a pandemic which is started with Wuhan, and all the labeling has gone to the China. Now China is back to the normal and we are suffering. And who gets the blame? China gets the blame. We are the maximum cases now. We are the second in number in the world, but we are still blaming China for this. There are a lot of conspiracy theories. China has created this. This is a lab created virus and this is spreading because China has created a biological war, and these are all conspiracy theories. I must tell you, this kind of pandemics has happened in the past. The corona pandemic, even the MERS and SARS-CoV-1 had come earlier, but now with the COVID-2 having spread all over the world, we are trying to find the person who sort of spread this disease, and it's very difficult to pinpoint, but there are a lot of conspiracy theories associated with this. This has caused a lot of derogatory headlines in the newspaper. We have seen many people, even the Trump accusing Chinese government for doing this, but again, these are all may not be valid truth. So not only the children, we have seen the psychosocial impact on the healthcare workers. This has caused a lot of psychological impact on the healthcare workers themselves, and it is quite complex and incompletely understood. All of us, the healthcare workers, which we are sitting here, who are working in the corona ward, non-corona ward, has gone through this psychosocial impact of the corona. many of us, at least 1 in 3, 30% of the healthcare workers has gone through a state of depression, whether it's a mild, moderate, or severe. At certain point of time, we have felt that the disease has definitely caused the symptoms of depression in us. Few of us has lost their nighttime sleep, insomnia, commonly seen, lot of stress, fear about the disease, anxiety about poorly known contagious disease. We hardly know much about this disease, though gradually as the time is progressing, we know certain things which could be fixed about the disease, but there are still unknown facts about the disease. This has caused a lot of anxiety, and which is more commonly seen with the healthcare workers, because people look up to us to give them the answer what this disease is all about, and we say we do not know about this. This gives a lot of stress and anxiety to ourselves. So there's a heightened self-perception of danger by lethality of virus. We ourselves, as a healthcare worker, we have labeled this as a highly lethal virus. Though the fatality rate is moderately less for this virus, we have labeled this as a highly lethal virus, and this itself has caused a lot of fear and anxiety in healthcare workers. There's a lot of performance pressure. All of us are working in a corona ward, non-corona wards. In our OPDs, there's a lot of pressure on us to see the patients or to check the patient, and there's a lot of fear that probably we will catch this disease, and this definitely causing a performance pressure on us. Overwork. Needless to say, the people who are working in the COVID ICUs, COVID wards, they have a tremendous work to do with the PPE kit on. They always feel that probably the PPE kit may not be adequate enough to prevent them from contamination, which causes a lot of frustration and frustration in the mind of healthcare workers. This also gives, they feel that we are unable to give an optimum care to the patient, probably because of you are using a PPE kit. You may not be able to examine the patient in a way properly which you may want to. So this has caused a lot of abnormal stress symptom, and this stress symptom, let me tell you, are with the studies which are coming up, are found with the more profoundly with the female healthcare workers. At least 1 in 3 of them are suffering from either depression or insomnia, and this is the studies which has proven this. Feeling of isolation and worthlessness among non-essential healthcare workers. Those people are not working directly into the corona wards or corona patients. They feel that they are not worth enough, because in the pandemic you see only corona patients, and if you do not see much patients, or if you are not contributing by way through which you should actually, then you feel that you are not worth in this pandemic. There's a fear of bringing home the disease and infecting our near and dear ones. Each one of us has this fear. Everyone, we know that we are working in the corona ward or a non-corona ward. There's a high chance that you might catch the infection and you will bring this home, and your near and dear ones can get affected with this. There is an intense feeling of vulnerability because of lack of definite treatment. There's no definite treatment which is available, and there is no preventive vaccine also available. So we feel that we are vulnerable. We are the healthcare workers working in the front line. Probably you are most vulnerable population. There's anxiety because of possible asymptomatic transmission. As you know, there's a patient in front of you doesn't have any symptom, but as we have heard that there's a certain number of cases who could be asymptomatic carrier. There's a high anxiety that we may catch the disease from that asymptomatic carrier, and the incubation period is highly uncertain. They have said it ranges from 3 days to almost 7 days, 10 days. So there is no certainty about the incubation period. We have seen a recent cases of assaults on doctors. The COVID patient has died. There has been some assault somewhere in the hospital. This has definitely created a panic. Loss of a healthcare worker itself has caused lots of anxiety and panic in the healthcare workers. So there is anxiety because of inadequate PPE supply. We know that there was a quite acute shortage of PPEs in the earlier days of pandemic, and we are quite worried that will we get some supply of PPEs to check the patient. There was a recent news of a shortage of oxygen supply in most of the corporate hospitals and the government hospital as well. So there was a fear, and there was a capping on by the government on this oxygen requirement. There was some funny news which was going on that only 12 liters per day should be given to a certain patient, and it was all misleading to certain anxiety and fear in the healthcare workers. bed not available, very common situation. Pune has gone through, Mumbai has gone through this situation. There are hardly any bed available in the hospital. There are a lot of calls from the relatives, from the friends to get us a bed, and we were not able to get them a single bed in the corporate hospital, even the government hospital. So this was really grave situation, which was causing a lot of fear and anxiety in the healthcare population. Of course, there was a certain failure of governments at some point of time, though it's a local authority, be it's a state government, whether it's a central government, there are always some kind of failure at the government. I may not label it, but the government has to take the initiative and make sure that you are forming certain guidelines to make sure that the healthcare workers are safeguarded. So the very important topic, the psychosocial effects on children. It is very crucial topic, but apparently it is overlooked, and it's sadly that children are suffering with the psychosocial impact of this COVID way too much than what adults could even imagine. There is a direct effect on their cognition, emotional and psychosocial skills, which you are observing currently. There were community-based virus mitigation programs like closure of schools, which are announced. The playgrounds were closed. The parks were closed. This has caused a lot of adverse psychosocial effects on the children. There was a disruption of usual lifestyle, which promotes the distress and confusion among the children. They are homebound continuously in the home, and they can't go to the mall. They can't go to the park. They can't go to the school. They're thought that this is something unusual which is going on. This has caused a lot of depression, distress, and confusion among the children. They have become demanding nowadays. They have become demanding while coping up with this situation. They have started demanding certain things which probably adults and parents are not able to sort of fulfill them. They could show impatience, annoyance, and hostility that can predispose the overly pressurized parent to sort of take up some violence, could be a physical or mental violence, which is actually impacted greatly on these children. So there are different stresses which we have found out in children. It could be a monotony, sitting at home doing nothing, or just attending the online school, same daily routine has caused a lot of disappointment in children. There is lack of face-to-face contact with their classmates, friends, teachers. This has definitely impacted their lifestyle. There's lack of personal space. You will say, what is the personal space of children? When the child used to go to the school, they used to enjoy their own space. When they are at home, they are missing that personal space. There could be a family financial losses causing a lot of distress in children. This can really hamper them mentally as well. So home confinement and fear of contracting infection causing undesirable mental reactions in children. They're all the time hearing about this corona. Parents are discussing over phone to their relatives, to their friends. They are at home, children at home, listening to what their parents are going through. And this has definitely created a lot of mental confusions and anxiety in children's mind. This in a long term may develop phobia or post-traumatic stress disorder in children because they are learning things which probably may not be appropriate with their age. So probably the post-traumatic stress disorder is upcoming thing in children, which we have to be careful about. The separation anxiety prominently observed in children of healthcare workers. The healthcare workers' children they are worried whether my father will get the corona, he'll be isolated, whether he will be coming home or no, or those children who has a single parent. So they are also worried about the separation anxiety. So all this problem in children because of the psychosocial impact of COVID. So online classes and assignments have increased screen time. All of us know that they are using the mobiles for their online classes and their homeworks and their classwork. This has increased their exposure to the online content, which may not be appropriate to their age. So it's very important that you keep a watch on that as well. There could be an adjustment difficulties with new normal. They may not like to use masks, frequent sanitization. They may not follow this new normal rule. So addressing specific psychological needs, healthy lifestyle, proper hygiene advices, and good parenting guides can help the children tackle the adverse psychosocial effects. Children with pre-existing psychological adversities like autism, they are badly affected because of disruption of their therapeutic counseling sessions. what are the suggested intervention? What exactly can be done to sort of tackle this issue of psychological impact on children? Proper parenting is very, very important. All of you know that parenting is love with discipline. Love without discipline is totally pampering, and love with discipline is parenting. So proper parenting is very, very important. The use of mobile or the screen has to be limited to only online classes and online study material. Apart from that, you have to restrict the child, limit the child usage of mobile and the screen. There should be a clear message, direct message, open message, detailed information to be given to the child about what is disease all about, how it is transmitting, and what are the precautionary measures he should take to avoid the contraction of the disease. The child should maintain his sleep cycle, make sure that he is into some physical exercises schedule. That is very, very important for them to keep healthy, and educate about proper hygiene practice. Again, I reiterating the fact that every kid before the school reopens must know what are the basic hygiene principles all about, and then only we can look for the school reopening, successful school reopening. So what is the conclusion from our session today? The COVID-19 pandemic has clearly shown us a virus can negatively impact our lives even in the 21st century, and simultaneously made us realize that the greatest assets of mankind are health, peace, love, solidarity, and knowledge. It's very, very important. I thank you again, all of you, for your patient listening. I thank you, panelists. I thank you, all the friends and colleagues and teachers, for participating in this webinar. Thank you so much.
Thank you. Thank you very much, sir. Very nice elaboration. I would like to ask you, hello?
Yes.
What are the possible symptoms in children with anxiety? Because due to corona, anxiety in the children has raised. So what are the possible symptoms in children?
So the symptoms of anxiety in children could be variable. It's very difficult, it's very complex, and it's very poorly understood. Children could actually show signs of impatience. They could be annoyed, they could get angry very easily. They could have a poor attention span. They could have a poor appetite, as simple as poor appetite. They could show variable symptoms like inattention, maybe they could have a chronic abdominal pain, non-specific abdominal pain. They could present with headache, non-specific headache. They could have a variable presentation. So all this psychosocial impact of COVID on the children could be sort of understood with this non-specific symptoms of headache. We have seen some cases of frequent sighing. Child is only coming with a sigh episode, big sigh episodes, and there's absolutely nothing in the chest. Child is absolutely normal. There's no history of contact. There's no history of any illness as such, but they are presenting only with the sinus because of the anxiety. So this could be common symptoms of anxiety in children.
And my second question is, what are the best activities to keep children engaged? Because a lot of parents are complaining our child play with mobile, you always watch television. So what are the best activities to keep them engaged?
Screen time has already increased a lot. If you see that every child has the mobile in their hand, and we have to make sure that the child is engaged with the activities which could give better cognition in children. So mobile is a very passive activity and can give a lot of violence to them, and may not teach, child may not learn anything from the games from the mobile. So it's very important the parents are offering board games to them, the box games which are available. Then you could actually have a drawing sessions, craft sessions. You could actually engage the child in different pretend plays. This will definitely keep the child engaged and away from the screen time. So the activities which could be done with the fingers or the hand should be encouraged, not the mobile, but actual drawings, crafts, many things. Like you can actually design a treasure hunt at home and make sure that the child is engaged with different new ideas, because as I told you, there's a lot of boredom in children because of this, and mobile is the simplest getaway for the parents. You give a mobile to your child's hand and child is very, very happy. Unfortunately, that should not be the way out. You have to make sure that child is engaged with the activities which are creative in nature.
Then my next question is, sir, when will be the reopening of school expected, and what are the possible guidelines specific to school reopening?
So IAP has recently on 12th of October 2020 has come up with nice guidelines about the directive to school, because when it is concerned with the kids, we are the one who are going to tackle this question. When is the school going to reopen and what should the ideal way to open the school? So there are certain guidelines which the IAP has come up with. First of all, with the geographical distribution, variable geographical distribution of COVID, in each district, probably the timing of reopening of the school could be different. Some have seen the peak of the disease, some are still to get the peak of the disease. So it's the local authorities who is going to take this call about opening of the school. More so, there are some guidelines when to reopen the school. So if the district has shown a steady decline in number of cases over 2 weeks, steady decline, I mean there's a persistent decline in number of patients which are defined by less than 5% positivity rate. So if you check 100 people in the community and the less than 5 we are coming positive, probably that is a good sign. That could be an indication or a good sign that probably the schools are ready to open. Or over 2 weeks period time, there are less than 20 cases per 1 lakh population. So that could be one indication where the school can reopen. And phase-wise reopening of the school is very, very important. School may not reopen suddenly. There could be geographical changes over the opening of the school. Some areas will open the school early. Some mediums will open early. Probably primary school will open little later, or secondary school will open little earlier. And even in that, some children will get, I mean, those who are want to opt for the online school, they could still opt from the home attending the school, because some school has opted for giving the material to learn on this online, so that those children can still be at home and learn from home. But those who want to join the school, probably they will have to do it in a phase-wise manner, very, very slowly, with lot of precautions and screening at school for children, because as you know, they may not suffer more, but they could be a asymptomatic carrier and they could bring the disease home. If you have elderly at home and kids at home, if they are going to the school and they become an asymptomatic carrier, it's a problem for the elderly at home. So it has to be done cautiously and slowly and gradually. So we don't expect the school to reopen even post Diwali, but the call has to be taken by local authority by seeing the numbers and the positivity rate. Thank you.
Okay. Thank you, sir. Thank you very much for very nice elaboration of the topic. Over to Ghadge, sir.
Thank you, Dr. Mahesh. Definitely, your lecture is very informative as far as the psychiatric problems in children are concerned. That will be definitely helpful for pediatricians also to know what things are to be done, what things are not to be done, when school is to be opened and when it is not to be opened. All these things, they are definitely informative. Now I will switch over to my topic, that is post-COVID syndrome overview and its clinical management. Already Mirgunde sir has talked a lot about the clinical presentation in neonatal and post-neonatal life in pediatric practice. Sagar Lad sir has definitely given a very important and very big message for post-inflammatory COVID syndrome. Definitely it is helpful for all pediatricians, because majority of the times, even though pediatric patients are less, critical patients are very minimal, we definitely had the COVID infection, which is likely to occur in pediatric practice and which will be having a great impact, not only for this period, but also for generations together. So we'll start what is this post-COVID as far as the general information is concerned. These are the signs and symptoms involving multisystem, either in asymptomatic patients or mild acute illness or after recovery from moderate to severe COVID illness. This can be again considered as an acute long COVID or chronic long COVID, depending on how much time this COVID is persistent. If the signs and symptoms persist for more than 3 weeks, normally what happens, about 85% of COVID patients, they recover from symptoms within 2 to 3 weeks. But if it persists for more than 3 weeks, it is called as acute long COVID. And if it persists for more than 12 weeks, it can be considered as a chronic long COVID. Less than 5% patients will have a chronic long COVID. The symptoms recovery may be complete or partial as far as the signs and symptoms are concerned, but radiological X-ray and HRCT requires for clearance maybe for 4 to 6 weeks. 32% of the patients may have worsened picture radiologically, and 9% have a pulmonary fibrosis recovered from ICU patients, even though it is not well documented in pediatric practice. It is definitely going to impact on the future outcome. Why some are affected and why others are not affected? It can be because of persistent viremia, weak or absent antibody response, or it can be relapse or reinfection with the COVID. It can be inflammatory or other altered immune responses. There can be mental factors, as Sulakshmi sir has already talked. What is the pathophysiology of the symptoms? This can be a long COVID. The symptoms which are occurring, as Sagar sir has already elaborated in detail how the viral injury occurs. In heart, it can rupture the lipid core, forming blood clots and myocardial infarction or vasculitis. There can be some comorbid infections with other pathogens like bacteria, viruses, or fungal infections, because with the COVID, the immune system is already deranged, and there can be a raw area either in the respiratory tract or in the gastrointestinal tract where the secondary infection can occur. There can be certain drugs like remdesivir, favipiravir, tocilizumab, steroids, hydroxychloroquine. All these drugs, even though they are little bit safer in adults, they can have a bad effects in pediatric practice because there are no trials, controlled trials, which will show that these drugs are definitely safe for pediatric practice. They can have injury to the various organs. There can be hypoxic injury to the various cells, like what we see in the hypoxic ischemic encephalopathy, because most of the COVID patients, they suffer from hypoxia. The mitochondrial injury by the virus can be a problematic one. The mitochondria are the main respiratory organs of the cells. When the COVID infects the mitochondria, the energy production is definitely reduced, and that can lead to the damage to the cell. There can be injury due to the cytokine injury, as already Sagar has described in detail. There can be metabolic injuries because of either hypoglycemia, hyperglycemia, electrolyte imbalances, or acidosis. There can be precipitation of the malnutrition. In a borderline malnutrition patients, there can be hypotension, sepsis or shock, or there can be immune reaction. What follow-up strategy should be followed? First is, when the COVID patient is discharged from the pediatric ward, he should be isolated in the home for 14 days after the discharge. Ideally, PCR should be repeated after 2 weeks, but it is not possible, or it is not advocated at present. Follow X-ray and HRCT if it is done and showed there are opacities or there are ground glass appearances after 4 to 6 weeks till the complete resolution of the pulmonary lesion is seen. Pulmonary function tests are to be done on second week and regularly every month till the patient becomes asymptomatic. Regular follow-up is must. First follow-up is on the second week after discharge, second follow-up after third month, and third follow-up after 6 months. MRI of the joints and brain may be required if patient has the symptoms concerned with that. Post-COVID inflammatory symptoms syndrome has already dealt with the large sir. There are other symptoms which systems can be involved, that is the respiratory system. Patient may develop lung fibrosis, bronchiectasis, or reactive airway disease as recorded by Klingberg, the American Thoracic Society. They can clinically manifest as cough, breathlessness, shortness of breath. There can be chest pain called as lung bun syndrome in adults. There can be cardiac symptoms because of myocarditis, pericarditis, or microvasculitis or thromboembolic phenomena. Can be closest differential diagnosis for Kawasaki or toxic shock syndrome. About approximately 20% of the patients may have normal heart rate, palpitation, shock, or chest pain. There can be another important entity which one must consider, that is the brain fog syndrome, or it is also called as chronic fatigue or myalgia encephalitis syndrome. In this, the viruses can reach brain through the olfactory nerve or through the lymphatics or perivascular spaces. Cytokines like interleukin 1 alpha, interleukin 6, interleukin 8 can cross blood-brain barrier, can cause mitochondrial dysfunction, and can cause encephalitis-like presentation in brain, and can cause myositis-like presentation in the muscles. The cognitive dysfunctions may be seen as Sulakshmi sir has already described. There can be depression, loss of memory, profound anergia. There can be gastrointestinal symptoms like chronic diarrhea, malabsorption, and hepatitis. There can be weight loss and malnutrition, nausea, vomiting, decreased appetite, loss of taste and smell sensation may persist. There can be decreased exercise tolerance. There can be disturbed sleep pattern, muscle weakness and wasting of muscles, neuropsychiatric complaints like depression and insomnia. Sometimes there can be middle ear pain. Sometimes acute deafness is also known. There can be tinnitus also. There can be headache, blurring of vision, sometimes cardiomyopathic picture, chest pain, arthritis. What follow-up you should look in the COVID patient? First, ask them whether the child is given regular medicine. Whatever medicines you have advised, especially those medicines which were started in the ICU, like aspirin or sometimes steroids, whether they are taken properly or not. They are keeping social distancing, they are following proper diet chart, exercise, and what is the status of recovery from their symptoms? Are there any new symptoms? And there should be a record of pulse oximetry, pulse, BP, and temperature if possible. How do you clinically assess this? First, take the history properly. Take the history from first day of symptom of the clinical presentation where the COVID symptoms are started. Sometimes what happens, there are no symptoms at all, but the symptoms reappear after 4 to 6 weeks. Now, what are the current symptoms? Whether there is cough, fever, dyspnea, or chest pain, then you have to do the examination. First, it's all vitals are to be checked. Pulse oximetry is must. What is the functional status? And respiratory examination, the detailed GIT and per abdominal examination is must. These investigations should be repeated depending on the clinical status of the patient. There can be CPC, X-ray chest or HRCT if there is a significant respiratory illness which can remain abnormal for more than 12 weeks. Then you have to repeat the LFT, RFT, then CRP, troponins, D-dimer, CPK, LDH, ferritin, then BNP, ECG, 12 lead, then urine routine and microscopy, and pulmonary function test. These are must. Now, what is the management? Medical management is, as Sulakshmi sir has already told, listening and empathy. We have to listen what are the problems of the baby or the patient and the relatives, and it should be with the empathy and not with the sympathy. What is the difference between empathy and sympathy is? Sympathy is just you say you are sympathetic for that patient. Arey, what happened? Your baby had a COVID. He was very bad. We have tried to save him. But with this sympathy, along with the parents, along with the baby, you are also stimulated. Your thinking is also stimulated, and you can have a autonomic disturbance also. You can have tachycardia, you can have raised BP or irritability. But in empathy, it is proper listening, thinking what should be done for that patient and what are the ways with which I can help this patient. This is the empathy. It should be proper. Then symptomatic treatment for fever, paracetamol, then supplementation of multivitamins like zinc, vitamin A, C, B complex. Consider antibiotics if there is infection is suspected, because this is whatever we are seeing, this is after 4 to 6 weeks of the COVID infection. Then if the child has cytokine storm, as Sagar has already described, you can start steroids and aspirin, which should be tapered within 4 to 6 weeks. and treat if there are any specific complaints. During homestay or during home, they have to manage something that is a self-management in the home. First is pulse oximetry. You have to give the pulse oximeter, or patient has to arrange the pulse oximeter in the home. He should do the pulse oximetry properly. He should keep the record. There should be a general health, like you have to advise the proper diet, balanced diet. Proper rest and relaxation of the babies is very important, because babies, once they are recovered from the illness, they don't listen to anybody. They will start exhausting games, then self-pacing and gradually increasing the exercise as patient can tolerate. Then some achievable goals, as Mesh has already described, and some social and cultural support has to be given to the baby and to the parents. How do you do the pulse oximetry in self-monitoring? In first 5 to 6 days after discharge, 6-hourly record is must. If there is persistent dyspnea, desaturation with exercises, or if there is a fall of 3% oxygen saturation, it definitely requires the further management and further investigations. How do you do the rehabilitation in these patients? Pulmonary rehabilitation may require 6 to 8 weeks. There are certain exercises, they are called as micro exercises or muscle strengthening exercises and energy expensing exercises. These micro exercises can be just like a neck rotation, shoulder rotation, hip rotation, knee rotation. Because of these rotation movements, the muscles which were already having a pain, which were already having a wasting, they can improve their circulation, lymphatic drainage is also improved, and these patients, they recover fast. Other exercises like walking and some massages may be helpful, especially those patients who are having myalgia. The behavioral modification, as Sulekshan sir has already described, first is accept the situation as it is, and tell the patient or a child and relatives that this is a disease with unpredictable nature. The disease can be, or baby can be normal at present, but can have a problem, as Sagar has already described, like acute inflammatory syndrome. There can be some breathing techniques. In the breathing techniques, we have to breathe with the nose. You have to tell the patient or relatives that make the child to breathe properly, especially those patients who have recovered from the illness. They need proper training for breathing. Use of diaphragm as a main muscle of the respiration is must, because there is a disadaptation in the illness. Instead of using belly muscles, the patient can have a use of intercostal muscles and the strap muscles of the neck as accessory muscles of the respiration. This has to be changed, and we have to change the breathing to the diaphragmatic breathing. Then some breathing exercises like chest physiotherapy, peak flowmetry, then balloon inflation, then some pranayams like Kapalbhati, Basrika, and Jalniti may be helpful, especially those patients who had some respiratory problem in ICU, as well as who have recovered and restarted the problems. How the cardiopulmonary rehabilitation is to be done? It should be slow and gradual. Sometimes may require beta blockers if there is a persistent tachycardia or ectopics. 20% of the patient may get all these symptoms after 4 to 6 weeks. As Sagar has already described, ECO study for myocardial dysfunction, ejection fraction, and coronary aneurysms or dilatation, we have to do it. ECG may be required if you are suspecting some conduction disturbances. The neurological rehabilitation, especially for the brain fog syndrome or the patients who have some problem with his memory, some problem with his concentration, there should be health education. And if the child, physiotherapy may be required for the weakness. Paracetamol for myalgia and fever, pranayama and meditation are definitely good for the neurological rehabilitation. Sometimes, as Sagar has already described, there can be patients with meningoencephalopathies, there can be patients with the various cranial nerve palsies, or there can have reappearance of the seizures if the patient has already seizures, or new seizures syndrome may be developed in future time. So this is all what one should do during the COVID infection, what one should do during the recovery, and what is to be done after the recovery, and what factors are to be considered as far as the post-COVID syndrome is concerned. Thank you. Thank you.
Thank you, sir. Thank you very much, sir. Very nice elaboration, sir. I have some doubts, sir. What red flag signs should be observed during post-COVID illness, sir?
Post-COVID illness, we have to observe the red flag signs. That is the important sense as far as the patient may go in a state of multi-system inflammatory syndrome, or they can have some problems which can lead to which investigations may be needed. These are appearance of fever. The patient was asymptomatic before, now he has developed fever. There is a cough, dyspnea, exercise intolerance. There can be GIT symptoms like nausea, vomiting, or loose motions. There can be COVID-2 syndrome-like presentation, which is not seen in India, but outside the India. There can be inflammation, arthritis. There can be some problems like altered sensorium, irritability, sometimes neurological manifestations like neck stiffness. There can be bradycardia. There can be ectopics on clinical examination. All they are called as red flag signs, and if they are there, the child is to be referred back to the center.
Okay. Thank you, sir. And then my next question is, what is the basis of post-COVID breathing exercises, and which are the best for children?
Very good question, madam, because most of the times for children it is very difficult to train them for the exercises as far as the respiratory system is concerned. The basis of these post-COVID breathing exercises is that our chest is having three types of breathing mechanics. Upper ribs, they are attached anteriorly to the sternum and posteriorly to the vertebral column. They move like a pump handle. Lower ribs, they are free. They move like a bucket handle. But main muscle of respiration is diaphragm. What happens routinely, majority of the patients, only 25% of their lung compliance is used for respiration. In the patients, if we use the whole of the lung capacity for oxygenation, there is a definite chances of recovery from the COVID respiratory illness at the fastest. Because what happens, at birth, there are almost 30 million alveoli. At 3 years, they go up to the 60 million. And at the age of 18 to 25 years, they become up to 90 million. What is this indicates? All the time, the breathing which is occurring or lung development which is occurring in a gradual state, not like other organs. The lungs are the organs which develop gradually. There is a growth, development, and maturation which is occurring continuously up to age of 25 years till his total height is achieved. So in this, what happens? Or whatever alveoli they are developing, whatever terminal bronchioles they are developing, they need some modulation, because the corona infection is involving type 2 alveolar cells. They will definitely damage to the respiratory tract. There can be chances of fibrosis. There can be chances of reactive airway diseases. So if you want to avoid this, you have to train the people of breathing, because this breathing will definitely help you for the reopening of the pores of Allen and Lamb which are present in the alveoli. They also help for remolding of the respiratory tract for the future development. So that's why type 2 alveolar cells, they have minimal, or this is developing stage. That's why S2 receptors are minimum. Pediatric patients developing COVID infection are less. But if they develop, they can have a problem. So to avoid this, we have to teach them the breathing exercises. First breathing exercise is just, I will narrate how to do it. First is abdominal breathing. How do you do abdominal breathing or belly breathing? Here, ask the patient to sit comfortably. Make abdomen straight, back straight, neck straight. Relax the neck muscles and shoulder muscles. Take a deep breath like this. put the hand on the belly, feel that your belly or tummy is coming out, it is pressing to the abdomen, then give the breath out with whistle like sound. This is called as belly breathing or diaphragmatic breathing. If you tell the patient that you have to do this, they will definitely do it. Second is bunny breathing. What is this bunny breathing? Ask the patient to do the position like a bunny. Take a deep breath in a jerks like this and blow it out like a bunny. So this is bunny breathing. Definitely patient will enjoy it, and that will increase the lung compliance. That will increase the mobility of the lung, so that whatever oxygenation is there, they will improve. There can be other respiratory exercises like Kapalbhati. You have to do like this, or you can ask the patient to say Onkar. That is, I will demonstrate how it is to be done. Take a deep breath, then expel it out with words like this. What it will produce? It will definitely expand the lungs. It will relax the baby, and the babies will definitely enjoy it. Then another breathing is deep breathing. That is also I can demonstrate to you like this. Close the eyes and utter a word like What helps? Just it closes the glottis, and whatever air you are pushing out, it works like a PEEP, PWP. It increases the end expiratory pressure with this sound, and definitely tries to heal the whatever inflammation is there. Thank you, madam.
Thank you, sir. Very nice elaboration, sir. Then my next question is, sir, what is the strategy for wearing mask in public places for children?
All these recommendations, what CDC gives is you have to use the mask whenever you are in the public places. But for child, it is said that you should try to use the mask after 2 years of age. But this is not advisable as far as the India is concerned, because there is a rampant spread of the infection. So we have to use the mask whenever we go into the public place. Here, certain precautions has to be taken. First is mask should be adequately covering nose, mouth, and chin. Baby, when he is wearing mask, there should be proper hand washing. There should not be touching the baby to the middle of the mask or any part of the body. Then mask should be proper placed. It should not be removed intermittently, because baby has, when you are going outside, they want to remove the mask, or they sometimes chew the mask. That should be properly done, and you should avoid this. Thank you.
Okay.
Right.
My next
Any other
question is,
question?
sir, for attending schools or for traveling, how we should give certificate to the children?
Certification is very important issue as far as the COVID is concerned, because the schools are going to open up, because various theaters, malls, they are again going to open. Some babies are to be going back to abroad, their places where their parents are working. Here certification is important. While giving certificate, first thing you have to do is the patient should have a report, either positive or negative, as far as the PCR antigen or COVID antigen is concerned, with the PCR test. Second, the baby or patient should be asymptomatic for last 10 days. There should not be any fever, cough, or dyspnea, or any other symptom like loose motions or CNS involvement. And third, if the baby is positive, at least 2 to 3 weeks have elapsed without any symptom. If he is positive, again, you may require to do the RT-PCR test done. If it is there, then you have to write there that this tests are done and baby appears to be non-communicable. This type you can give the certification.
Okay. Thank you, sir. Then my next question
Thank
is, what should be routine vaccination schedule during COVID-19 pandemic? Can we suspend vaccination for some months? Or
Yes.
and what precautions should we take during vaccination?
A very good question. As Mirgunde sir has already answered this, but I will like to add something. The pediatric vaccinations are must, because this is the only way with which we have conquered the various infectious diseases. For last so many years, we are definitely proved that this will definitely help. With the COVID, as we know, there can be some immune depression or immune modulation. There are lockdowns, there are other problems as far as the fear of the COVID-19 infection is concerned. The parents won't like to bring the baby to the vaccination center. So we have to think what should be done. First, if the baby is asymptomatic, baby doesn't have fever, baby doesn't have any signs and symptoms which suggest that he has a COVID infection, you have to go for the vaccination as a routine schedule. Because if the vaccines are given in a proper time, they will definitely help. And if the vaccines are not given in a proper time, it will not be helpful, especially if the rotavirus vaccine is given after 7 months. It may not be helpful, or it may produce sometimes interception. So vaccines which are given in the first year, there is no alternative for giving vaccine. You can suspend it for, or you can postpone it for 7 to 8 days. If they are postponed for more than that, what happens when you give the vaccine? All pediatricians definitely know that whatever antibody response is there, first is IgM, then IgG, and when the vaccine is given at the descending limb of the IgG, it will definitely give an exaggerated immune response, and it will produce some memory cells. That's why first year vaccines, there is no chance for suspending the vaccine for 8 days. If it is suspended for more than months, there is a trial in Africa that 6 months vaccine suspension will definitely increase the chance of 25% for again appearance of the endemic or a pandemic of other communities like diphtheria, polio, pertussis, measles. For the patients who had a fever, but they are not tested to be COVID positive. Here, the fever is there. You can wait for 10 to 15 days because incubation period is 10 to 15 days. If the patient becomes normal, you can go for the immunization. If patient is having proved COVID positivity, if he is clinically stable, the pediatrician is the one who can determine whether the child is able to accept the vaccine or not. If the patient is clinically stable, he doesn't have any signs, symptoms which can avail him from getting vaccination, you can definitely give vaccine to the patients who have COVID illness, but may be delayed up to 4 to 6 weeks. Then what precautions you should take while giving vaccination? First, as ICMR guideline has been already given, that all first year vaccines should be given in proper time. Second year vaccines may be delayed for a month. Other boosters and other vaccines may be little bit delayed if the time doesn't permit, or if the patient is not able to come to the hospital. Then all precautions like hand washing, social distancing, wearing of PPE kit, then avoidance of communication or horizontal transmission of this illness to the baby and to the relatives have to be taken care of. Then wearing of proper mask and giving proper dosage, all these precautions are to be taken.
Okay. Thank you, sir. My last but not least question, sir. What is the current status of COVID-19 vaccine?
COVID-19, very good question. COVID-19 vaccine is under trial. Almost 170 trials are going on all over the world. These vaccines are produced either this coronavirus, there can be attenuated virus, there can be killed virus, there can be some fraction like as sir has told, M protein or spike protein vaccines or fragments can be given. All these vaccines are developing all over the world. Russia has already declared that they have produced a vaccine. Russian Prime Minister has given the first dose to his daughter also. But whatever vaccine status is there, that is in the almost third phase of vaccination. There are 5 phases of vaccination, but in emergency, after third phase, we can use the vaccine. In India, 2 vaccine companies are now producing vaccine. First is Bharat Biotech. They are along with ICMR and NIV. They are giving vaccine. They are producing vaccine. That is in the third stage. That is a killed vaccine. The cost of the vaccine is around 225 rupees, and that will be available recently or soon within next 2 to 3 months, as Prime Minister has already declared. Then second vaccine which will be available, that is produced by Serum Institute, that is with the Oxford University. This is the only mRNA vaccine which will be available, that will be produced in a large scale in India. Then next vaccine company that has produced Novavax. Then Johnson & Johnson has produced one vaccine, but they have found that with the vaccine second phase, they have found some abnormal symptoms. That's why the vaccine is stopped. So this is current status, and some vaccines may be available after.
I think there is a network issue. Okay. We will wait for Dr. Sharad to join in. I think he has logged off. So what I'll do, I'll take up a questions which is by the audience. I think most of the questions are well asked by Dr. Swapna and Dr. Neelam, and most of the queries has been resolved. I'll take up 4 most relevant questions. We have nearly hundreds of questions which are here, but I'll take up 4 most questions which are unanswered, and we can get answers from you. So the first question is that, is there any specific dietary recommendation for the children or any food that will help to boost the immunity for the COVID children or any children to that matter, so that it will protect against any viral or the bacterial infection in this particular time?
Dr. Sagar, can I answer this?
Yes, absolutely.
Dr. Shirish, with your permission, I'll answer this.
Yeah. You continue.
So the most relevant question in today's time: what diet should be offered to the kids during this pandemic? The simple answer is whatever you are eating before pandemic has to continue. You cannot eat anything new, or you should not try to eat anything new. This is also considered as a misadventure. You're not supposed to eat something which is going to be totally new to you, because it itself can cause a lot of allergy issues to you. So whatever is your traditional food at home has to be consumed. And तहान लागल्यावर वीर खोडण्यात काही अर्थ नाहीये. जे काही तुम्ही आधी खात आलायत हेल्दी राहण्यासाठी तेच करायचंय, दुसरं काही करायचं नाहीये. So it is very important to let parents know that you have to eat your own traditional food. Whatever you are cooking at home has to be continued. To be more specific, fruits, vegetables, grains, pulses, dairy products has to be consumed in an adequate manner. Everything has to be consumed as a regular thing. Nothing special, no special dietary recommendation during this pandemic.
Okay. So, Dr. Shashir, you would like to add something to this?
Yeah. No, absolutely what Dr. Sulakshmi told is absolutely correct. Least processed food without preservative, whatever we were eating pre-corona, natural food we should take. And obviously it should be balanced, and green leafy vegetables and fruits are, they contain these all vitamins we were supplementing to infected patients. They should be taken by non-infected children also, and that will be protective also.
Okay.
Yeah.
Sure, sir. So there is another question which has been asked, that is there any specific drugs or something that you would recommend to children for the immunomodulatory or immunoboosting effect in the children?
Can I take?
Yes, yes.
Yes, sir, please.
Yeah. As per any authentic recommendation, it is not at all recommended. But there are certain medications. Even government is also recommending through Ayush Mantralaya. These Ayurvedic preparations are useful, but not for preventive purpose. They are for rehabilitation purpose. Officially, Chyawanprash and all these preparations, government is recommending on their site, Ayush Mantralaya and Ayush. So that is the only available evidence. Otherwise, as I said, this diet is very important, and whatever practices want to prevent, that should be followed strictly rather than searching for any drug.
So then what is your experience regarding use of probiotics? Like there are various probiotics which has been used in RRI and allergic rhinitis, which has got in the modulatory effect.
No evidence to suggest its routine use. They are being used in so many allergic conditions, it's okay. But they are not at all for prophylactic use of corona. And corona is not an allergic infection. So related to immunity, I don't recommend the routine use of probiotics.
Okay.
Anybody, Dr. Sulakshmi or Dr. Sagar?
There is no specific recommendation of use of any probiotics to modulate the immunity. There is no evidence suggesting the same. So again, probiotics are abundant in your own diet. So continue eating what you're eating regularly.
Sure, sir. So there is another question regarding why there is bradycardia in COVID patients. In the children, in few of the cases, it was described that there is bradycardia. What could be the reason?
Can I take?
Yeah, Dr. Sagar would be a better person to answer this.
No, the thing is that it behaving like the involvement of the conducting system, like viruses affect your myocardium. It involved your SA node, and because of the involvement of SA node, there is a bradycardia. What we have also seen in the dengue patient, that dengue patients sometimes become bradycardic. Even they need support to increase the heart rate. But this is because of involvement of conduction system, and if the child is hemodynamically stable, no acidosis, BP is maintained, and it doesn't need a treatment, and over a period of time, it is because of antibody that has formed against, it is autoimmune nature. So it is causing vasculitis. Says that same antibody is going to affect your SA node, and over a period of time, it is going to settle down. So that is the reason. Sometimes they get ectopic also.
Okay. So there is the question that in your first, second, and fifth case, the child had edema on hand and feet, and what could be the cause for that?
It is again the same vasculitis, because all this is because of vasculitis secondary to the autoimmune. Because coronary vasculitis, vessel, small hand and legs vasculitis, brain vasculitis, because of autoimmune nature is the main reason.
Okay.
Sometimes they are found to be hyponatremic. Sometimes they are found to be hypoalbulemic also. So hyponatremia and SIADH is also one of the reasons they become the edema of hand.
Okay, fine, sir. We will take up a last question, sir. Like, what percentage of the child have got reinfection? What is the percentage in your practice? Have you seen any child who are reinfected and coming back to you?
Now, the thing is that acute infection in children is less. What already Shishir sir has said. Acute infection is rare. And the post-inflammatory infection, so far I haven't seen reinfection. I think we are still in the evolving phase of the disease. We don't know what is the long-term sequelae. So right now it is very difficult to say whether that child is going to come back with cytokine storm. It is unlikely, but he definitely going to get some sequelae with this disease. Acute infection like an adult, if you get acute COVID, he might get a second time infection. But for children, I don't know. I don't think there is any available literature to this answer.
Okay. Okay, sir. Fine, sir. I think I'll take up the last question. What about the COVID and cardiomyopathy? I think the answer will be same, COVID and cardiomyopathy.
Yeah, but if you get involvement of myocardium, it is like a viral myocarditis. So even if you COVID-induced myocarditis, if there is a LV dysfunction, that LV dysfunction may take a time to settle down and child may land up in cardiomyopathy.
Okay. Fine, sir. Fine, sir. I think we all heard one of the excellent presentation. Till now, we were talking about COVID, and COVID. What after that we didn't knew. I think this all session, the topics were about what after COVID, the post-inflammation, how to treat, how to tackle, and how to manage. And you all have done a wonderful job and elaborated topic to a simplistic way. And we thank you for that. I would like to extend my vote of thanks to each and everyone who have made this webinar a resounding success. Firstly, I would like to thank Center Pharmaceutical for giving this excellent platform for the propagation of the knowledge. I would like to thank the Shashwatim team of Center who have worked relentlessly to make this webinar a successful webinar. First, I would like to thank Dr. Sharad sir for excellently moderating this session and elaborating his topic in a very interesting way. I would like to thank all my speakers, Dr. Shishir sir, Dr. Sagar sir, Dr. Mahesh sir, for your wonderful and excellent talk on the respective topics. I would also like to thank our panelists for being there today with us and asking one of the best questions so that we don't have anything left at the end. So most of the questions were asked in the beginning and made our doubts very much clear. And I thank you everyone and thank you for being here with us. Thank you. Thank you so much.
Thank you all. Thank you.
Thank you. Yes, sir. Yes.
Thank you.
Thank you.
Nice organization.